Hey, welcome everyone. Thank you for joining us for today's webinar sponsored by Clorox Healthcare and Mariposa Training. Before we get started, I have just a few admin items. First, if you have any questions, please use the Q&A feature, which you can find at the bottom of your screen. The Q&A includes an upvote feature for questions that you'd like to see answered first. The questions will be answered at the end of the presentation. A copy of today's presentation is also available for download in the chat feature. To receive your CEUs after this live webinar, you must attend for at least 50 minutes and pass a post-test that will be available at the end of the presentation. Please click on the link provided to complete the test. You will also receive an email with a link to the post-test following the webinar. Once you pass the post-test, you'll receive your CEU certificate. CEUs will also be available through the on-demand version, which will be posted to the Clorox Pro website in about 2 weeks. With that covered, I'd like to introduce today's speaker, Dr. Curtis Donsky. Dr. Donsky is an infectious diseases physician and hospital epidemiologist at the Louis Stokes Cleveland VA Medical Center and a professor of medicine at Case Western Reserve University. His research focuses primarily on epidemiology and control of healthcare-associated pathogens. I will now turn it over to Dr. Donsky.
Okay, thank you all for attending. Today I will talk about lessons that we've learned during collaborations between infection prevention and environmental services personnel. And the underlying theme is going to be something we all believe in infection prevention. You can improve what you don't measure. My disclosures are at the bottom. I've received research funding from Clorox and Ushio America, a company that makes far UV lighting. So my objectives will be first to describe the characteristics of common disinfectants, then to describe factors that may contribute to ineffective cleaning and disinfection, and finally work together so we can try to implement monitoring of cleaning and disinfection that really should involve collaboration between environmental services and infection prevention. So here are some commonly used disinfectants in healthcare settings. Showing some of their characteristics. So quaternary ammonium disinfectants are commonly used. You can see the contact time, 3 to 10 minutes for MRSA and VRE. They do not have dependable activity against Candida auris, but some products can be effective. So we always recommend looking at the EPA listing for specific pathogens when you want to know what your disinfectant covers. So for Candida auris, if you look at EPA List P, you can find out if a particular quat product is effective. And then they're not sporicidal. Quaternary ammonium plus alcohol disinfectants give you a little bit faster contact time. Hydrogen peroxide disinfectants commonly use, again, a very fast contact time, which is their major advantage. And they have activity that's pretty dependable against Candida auris. Again, not sporicidal, but if you have a high enough concentration of hydrogen peroxide, there's at least one disinfectant that has a claim, and you get some modest activity even with some other hydrogen peroxide products that do not have a claim. Peracetic acid products such as Oxycide are commonly used in a lot of healthcare facilities. They provide a sporicidal activity and are active against Candida auris. And then sodium hypochlorite or bleach products similarly provide broad activity against Candida auris, spores, and other pathogens. So we have very effective disinfectants that we have available for us that in healthcare settings, but we still have this problem, and that is that many studies have demonstrated that even after we use these products, contamination is common after we clean patient rooms. So here's a study we did in 30 hospitals in collaboration with APIC, where we looked at C. diff contamination in patient rooms after completion of cleaning. We were dividing this up by hospitals that use a sporicide everywhere in all patient rooms versus only in C. diff rooms, and with CDI rooms on the left and non-C. diff rooms on the right. And as you can see, if you look at the total there, we're finding about 10% of rooms still have C. diff contamination in them in C. diff infection rooms after completion of cleaning and disinfection, and about 5% of non-C. diff rooms have C. diff as well, either left over for some previous patient, or you may have an asymptomatic carrier of C. diff in that room. So this is the problem that we face, that we do not always achieve as good results as we would hope to have. And so here's a question for us, what is the most likely reason for positive cultures after cleaning? And I would say that we typically would choose A and B. Surfaces are not wiped, the EVS personnel are not doing the job as well as they should, or they're using the disinfectant incorrectly, inadequate contact time. And I think we probably pay less attention to C and D. Either, someone could be using an incorrect product, or that the disinfectant may actually, even though it's an EPA registered product, may not be working appropriately. And I think that's something that deserves more attention and that we will discuss. So here are some examples. So disinfectant being used incorrectly. So it certainly is possible to do this, use products in a way that's incorrect. So quaternary ammonium products in particular, binding of quaternary ammonium products to wipes is a significant problem if they're not used correctly. So in this study from Dr. Boyce, wipes reduce the quaternary ammonium concentrations to a variable degree when they were submerged for a long period of time. So if you have a bucket of your quat product and you put a bunch of rags in them and leave them sit there for a long period of time, you can see in this study, he looked over 240 minutes, and there was a variable reduction. Some products were quite good and not reducing the quat product very much in the top there. But several products, including one of the microfiber products and cotton, were significantly reducing the level of quat when you soaked rags for a long period of time. So, in this discussion, Dr. Boyce recommended that we should really be educating our personnel to use a dip and wipe method if we're using quaternary ammonium products that are not ready to use. So you dip and wipe and submerge for only 5 to 10 seconds and then apply the quat product. So one example of how you can use a disinfectant incorrectly. Here's another, which is thankfully not a frequent occurrence, but this illustrates that quat resistance can emerge with incorrect use. Again, another study from Dr. Boyce, who's really been a leader in environmental issues over the years. So in this case, they were doing a study and culturing rooms, and they found, surprisingly, that in one particular room, there was a tremendous increase in the amount of gram-negative contamination after cleaning the room. And so they went and talked to that particular environmental services worker and found that this was somebody who was not a regular worker and had used the same disinfectant bucket for months without ever really emptying or drying it. So quat was sitting at the bottom of the container with opportunity for bacteria to stay there and develop resistance. And so we found that this housekeeper had a bucket that was contaminated with quat-resistant bacteria. So here you see on the right there a lawn of bacteria. They put a drop of the disinfectant down in the middle there, and you can see there's a clear zone there. But within that zone, there are hundreds of colonies of these quat-resistant bacteria that are growing right into the quaternary ammonium disinfectant. So this, again, not frequent, but you have to be aware that quats have to be used correctly according to instructions. You can't, and you want to empty and dry your container if you're using just dilutable product. And here's another example, also thankfully not frequent, but of a disinfectant not working the way it should. So you have to be aware that of the characteristics of any disinfectant you're using. Dilutable peracetic acid disinfectants are relatively unstable in comparison to a number of other products. And so so for example, if you are using Oxycide, you would make it fresh daily. And there are some products where you can activate on site. And so we had switched several years ago to a product called Steriplex. which we activate on site. So there's a canister there of disinfectant with a small amount of concentrate under the top of the container. You'd push the top, release the concentrate into the solution down below, and you'd activate it and make fresh product, and you had to use it within a certain amount of time. And so after we switched to this product, we found that our rate of C. diff had gone up fairly dramatically, and so we were wondering if there was something wrong with the product. And so what we found was, if you look at the figure there on the left, the label said that we should have, and this is the concentration of peracetic acid, the label said that we should have 1,500 parts per million of peracetic acid. We looked at newly prepared product that had just arrived at our facility, and the level was 400, which is below the level that would provide sporicidal activity. And when we collected it from containers out on the wards of our environmental services people, it was even lower, less than 200 parts per million. So there was something wrong with the product. An alternative is shown on the right, which is working appropriately. And so there was a malfunction of the smart cap reservoir. So the concentrate was leaking down into the container during transportation. And so by the time you got the product and were ready to use it, it had lost its activity because, again, dilutable peracetic acid products can be unstable. So again, not a common scenario, but this, I think, raises the issue that we shouldn't just think that people are not doing their job correctly. We want to make sure that the products are also working correctly. So we have kind of embarked, after completing this recent study, looking at contamination with C. diff in 30 hospitals and kind of recovering from the pandemic. We wanted to do a post-pandemic evaluation of cleaning and disinfection, with, again, the concept being that, if we don't measure cleaning and disinfection, we can't improve it. And we really had gotten away from a lot of the things that we were doing before the pandemic, and we wanted to really kind of reassess where we currently stand. And so one of the things we did, finding contamination after cleaning, was, again, ask this question: is the product working appropriately? And so here was one of the questions that we started with: are automated disinfectant dispensers providing correct disinfectant concentrations? So, as you know, if you work in a healthcare facility, disinfectants are often dispensed from automated systems that take a concentrated container of disinfectant, dilute it with water, and provide you with a diluted product. And a number of previous studies have raised concerns about these dispensers potentially not working well. And so we did an evaluation of dispensers in 10 hospitals, 4 healthcare systems in 5 states around the US. And we did a very simple evaluation, just testing disinfectant levels and pH. You can do this very simply with pH paper and with a quat test strip. And so I'm going to go straight to the results, which were somewhat surprising to us. We expected maybe we would see a little bit of an issue, but this was a major issue. We detected malfunction of automated disinfectant dispensers in 9 of the 10 hospitals. The summary is shown there on the left is what we found from the dispensers. And then I would just say that a lot of these dispensers were quaternary ammonium products, but some were also dispensing oxycide. And what you can see is that about half of the product that was dispensed from the dispensers was just right. And some of it was too high, and that was often oxycide dispensers where the peracetic acid concentration, you do not want a concentration that's too high because it potentially could be hazardous to personnel. A number of them were too low, and as you can see, 15% of the dispensers we tested, there was no disinfectant detectable at all. They essentially were dispensing water. So the concentrate wasn't getting in at all. When we looked at in-use disinfectants, went out and collected from environmental services workers' carts, we found, as you would imagine, the same thing, with one additional finding, and that is that there were 4% of people who were working in EVS had told us they were using a disinfectant product, but when we actually tested what was in their container, it was actually a floor cleaner. So you were using a detergent and not a disinfectant, although they were under the impression that what they were using was a disinfectant. So our conclusion was that there's a need for improved monitoring of automated disinfectant dispensers. And I would just point out that, manufacturers are aware that there's an issue with these dispensers. So one of the companies very nicely puts this large poster by each dispenser and tells people to look for signs that the product is being dispensed based on the appearance and odor. And there's an optional pH check that you can use. And then there are a number of reasons it seems somewhat surprising, but what are some of the reasons why we're seeing this? So if you don't attach the container top correctly, if it's a little bit off, you lose the suction basically, and you're not pulling up product. If the amount of concentrate is running low in the container, if you have a very low level, the straw that sticks down in and pulls up the concentrate doesn't provide any disinfectant, and it's not necessarily that easy to see when the door is closed. The low product indicator can malfunction for one of the products, and so you can end up with a situation where there's no product being dispensed, even though the indicator suggests that it is. And then of course, I think anyone would say, well, how can it be that hard to tell if there's a disinfectant versus water in the product? And this is just an illustration of why that might be a problem. This is from our facility. So when we dispense Virex Plus, our quat product, from our dispenser, you can see it has a little blue color and is nicely foamy. When you dispense water, because there's still some detergent and things in the line there, you end up with this kind of foamy product too. So unless you're looking carefully, it doesn't really look like it's that far off from what it should be doing. So there are lots of reasons why disinfectant dispensers are an issue, and we recommend regular monitoring of these systems if you're using them. With every time you put on a container of concentrate, or intermittently testing whether these dispensers are working correctly. One question that we have is, can we identify new approaches to automatically monitor dispensers? So here's an initial evaluation that we're looking at other approaches as well. But we just published this evaluation where we looked at real-time detection of malfunctioning dispensers using colorimetric or hydrophobic wipes. And for example, at the bottom there is the hydrophobic wipe. If your dispenser is just dispensing water, it doesn't sink into the hydrophobic wipes. You can actually tell if it's completely malfunctioning. And then there are various colorimetric wipes, including on the top is a certain sanitizer for quaternary ammonium products, which turns color when you have an adequate amount of quaternary ammonium present. So this would provide environmental services personnel with real-time visual indication that their product is working correctly. So this or some alternative method is really needed to make certain that disinfectant is being dispensed correctly, because it's really somewhat difficult to regularly get people to follow through with doing pH monitoring or quat strip monitoring. Okay, so in addition to looking at automated dispensers, another thing that we did as part of our post-pandemic evaluation was conduct interviews with EVS staff and direct observation of cleaning practices. So interviews with staff allow you to identify knowledge deficits and maybe other issues that might impact job performance and things that might help make things more efficient for them. Performance observations, I would just mention that I think we often say that just visual assessments are not effective to tell whether something is clean or not, but the CDC does recommend, and others recommend, that there are intermittent evaluations that are really kind of performance observations, where someone goes into a room with someone who's doing the cleaning and assesses, watches and assesses how they're doing their job, making sure they're doing things correctly and answering any questions that they have. And this allows you to really identify variation in performance how much time is it taking, the number of wipes that are being used, level of cleanliness, are things being applied correctly. For example, we've had housekeepers where I've observed applying bleach and then immediately wiping, so there's essentially no contact time. Things like that you're not going to pick up unless you actually are in the room uh, working with people kind of on the front lines. So this is recommended by the CDC. It's an important thing that should be part of what we're doing to improve cleaning. And so we followed through with a kind of more complete, what we call a time and motion study of cleaning practices and performances. We did 26 hours of observation, including post-discharge cleaning, daily cleaning, and equipment cleaning. And we were looking at the time required to complete cleaning and other tasks that EVS personnel have to do, and appropriate use of products, including both ready-to-use and dilutable disinfectants. So here are some of our findings. So EVS carts can be a bit complicated. They carry a lot of products on average. The personnel have 6 different products on their carts and a variety of supplies. So they have to be able to sort through and figure out which are the sporicidal and non-sporicidal disinfectants. They have cleaners for various other types of things, toilet bowls, glass, etc. as well. And if we look at the time to complete tasks during terminal room cleaning, is shown here. So actually, on the right there, the blue coloration there, 38% of the time during terminal room cleaning is spent actually cleaning and disinfecting. A fair amount of time is spent, as you can see, doing a lot of other activities. So after you clean and disinfect, in the orange there, 5% of the time is spent removing residue left over from disinfectants. They want to make sure there's no residue left, making the bed, sweeping the floor, replenishing paper towels, removing trash. All of these things take time. And a fair amount of time is spent kind of identifying and moving to a new room if you're looking at the time for someone who's spending time doing terminal room cleaning. And there potentially are ways to make that more efficient. And then we looked at daily room cleaning as well. So in the morning, our EVS personnel go up to the rooms and doing it, they empty the trash and do some other cleaning. We recommend, I'll come back to this later, that daily cleaning should include some cleaning of surfaces in the room. But often what happens in many rooms, if there's no obviously visible dirt or soil, is you end up with a scenario where there's really kind of what Dr. Ratala likes to call trash and dash, that you are really, the primary goal in the morning is to get up there, empty the trash, assess whether there's anything that appears visibly soiled and needs to be cleaned. And so not a lot of time is actually spent wiping down surfaces. So as you can see in purple there, removing trash 33% of the time, gathering supplies, sweeping the floor, which is relatively routinely done, replacing paper products, and then only 20% of the time during daily cleaning is actually spent doing cleaning and disinfection. A fair amount of time is spent gathering supplies. For daily room cleaning, 12 minutes per shift. For our personnel who are doing terminal room cleaning, 26 minutes per shift. And a lot of supplies, they have to go down to central storage to get at the start of the day. And then they may have extra supplies in a cart, in a closet that's on each ward. So gathering supplies takes up some time for EVS personnel. And then our observations demonstrated that disinfectants are occasionally used incorrectly with incorrect contact time. Sometimes people have left the ready-to-use wipe canisters left open overnight. There's potentially crossover between bathroom and patient room without changing wipes or mops. And then we found in our facility that a few of our personnel would sometimes mix products together. For example, a quaternary ammonium product plus sodium hypochlorite, which is definitely not recommended. And we found that, as others have shown, compliance with appropriate cleaning and disinfection practices in general increase with experience. So our most experienced on the y-axis cleaners often had the highest compliance scores. We had a score for compliance with all of the measures that we were following for appropriate cleaning and disinfection. And then I would just note that one other thing that we definitely observed is that EVS personnel are motivated to do a good job. Here are a couple of quotes for you. I clean the bed like I would like it to be clean, because it could just as easily be me laying there. I mix Virex with bleach, so they're doing something that we're not recommending, but the reason for the mattresses, the reason they're doing it because it makes it more friendly to the mattress, so they last longer. Here's another person. I use apple scent on the floors after I use Virex because it leaves the room smelling good. And then, you get to know the patients and they expect to see you, you get invested in them. So, in our experience, our EVS personnel really are by and large a strong group of workers who are trying to do the right thing. And then mobile equipment disinfection, I would note, is a task that is primarily assigned to clinical personnel. We're supposed to be wiping things down after we use them, with some assistance from environmental services. So, here we found, only 16% of mobile devices were disinfected after use. We observed 25 devices being used. All 4 of the disinfected devices had a canister of wipes attached. So here you see a vital signs piece of equipment here where where we have a canister of wipes attached to the device. We have that for our bladder scanners and for other types of equipment as well, which makes it more efficient for personnel. If the wipes are right there, it's easier to grab them and wipe the equipment. In 9 of 25 observations, 36%, the mobile device was observed to go directly into another patient room without disinfection. In one case, there was a contact precautions room where someone used it, came out of the room with no cleaning after use. So I'll come back to this point, but mobile equipment is a major challenge for all of us. So the last part of the discussion today will be about, we've kind of set the table with kind of things that kind of our post-pandemic evaluation, kind of where we are, what we need to do to improve again, and kind of get back to where we would like to be with environmental cleaning. So the final part of the talk will be on kind of interdisciplinary collaboration to optimize cleaning and disinfection, which is essential. So here are some recommendations for infection prevention in EVS. The CDC and many experts have recommended that infection prevention in EVS should really be a team to ensure adequate cleaning. We should have standard operating procedures, some strategy for education of EVS, direct observation performance in addition to monitoring where you're not interacting with individuals. And then we should be doing what we can to recognize the importance of EVS staff. This is just an example here of a little kind of fun quiz that they had at the University of Nebraska for EVS personnel. So routine objective monitoring is recommended by the CDC and by others. There are a couple of methods that people commonly use. Fluorescent markers are developed by Phil Carling several years ago. Is an excellent way to assess the thoroughness of cleaning. You can use place a fluorescent tracer down on a device, on an object, and then use a black light to visualize that. And if it's if the device has been wiped, you know that you can assess that it has been thoroughly cleaned. ATP bioluminescence does not assess whether things have been cleaned per se, but it measures organic material. So that can be bacteria, food, bodily secretions, etc., anything that has ATP in it. This is a bit more kind of expensive, and it requires that you have these devices you have a swab that you swab the surface, and then you place it in the device and you get a reading, and you can provide immediate feedback. So many studies have demonstrated that you can improve cleaning with fluorescent marker monitoring. Here's just one example of an impact of an intervention on cleaning in 36 hospitals, led by Dr. Carling. So pre-intervention, and other studies have shown very similar findings. Pre-intervention, about half of items were wiped based on marker removal, and after post an intervention that included education and feedback, up around 80%. So you're not going to be perfect, but you can get really a pretty dramatic improvement in making sure that things are thoroughly cleaned. And then there's lots of evidence that you can improve cleaning with this technique. Here's a recent study where it was demonstrated that not only did they improve the thoroughness of cleaning using a fluorescent marker method, but they also reduced C. diff infection rates. And so this was a study in 8 hospitals, where 8 intervention hospitals and 9 control hospitals. So they had good controls. They used a peracetic acid disinfectant for daily and terminal disinfection in all rooms. So there's a substitution of this sporicidal product for non-sporicidal products in non-CDI rooms prior to the study. They reduced CDI hospital onset incidence by 50% versus controls, and you can see in the figure there, in the red line, the controls stayed about the same for their CDI rate, whereas the intervention facilities, there was a dramatic decrease. So this intervention included, as I mentioned, both the fluorescent marker monitoring and feedback, which improved the thoroughness of cleaning, but it was also a product substitution of a non-sporicidal disinfectant for routine cleaning and disinfection, being substituted with a sporicidal product. So the combination of both those, you can't say for sure if this was just the improvement in thoroughness of cleaning or if it was the product substitution, and likely a combination of both. There have been studies that have demonstrated improved cleaning after education and feedback based on ATP readings. So here's just one example of that, where they did before and after. And then there is one high quality study where they showed a reduction in MDRO infection or colonization with ATP monitoring and feedback. So in this, they had 6 intensive care units. It's a multi-center cluster randomized trial comparing ATP versus fluorescent marker monitoring and feedback. And in this study, ATP monitoring and feedback reduced MDRO infection or colonization. In this particular study, the fluorescent marker method did not. The ATP monitoring, interestingly, the reduction in MDROs was almost entirely driven by resistant gram-negative bacilli, which we tend to think of as being a bit less important in the environment in comparison to things like MRSA, VRE, and C. diff. But that drove their reduction in MDROs. So for both fluorescent markers and ATP monitoring, there is evidence in the literature of reductions in infections. So collaboration for our work with infection prevention, collaboration is essential if we want to sustain improvements in cleaning. So it's easy to demonstrate an improvement in cleaning for a short period of time or for a research study, but the hard part is sustaining it over a period of months and years. So this is a study from Mark Rupp and his group in Nebraska, where they had interventions that included cleaning checklists, education, fluorescent marker monitoring. They gave monthly in-person feedback to EVS from infection prevention and found that was the most effective intervention to sustain improvement. So they saw an initial improvement, and then things slacked off a little bit and then improved again. And the thing that appeared to be most effective in sustaining the improvement and thoroughness of cleaning was actually going in every month and talking to EVS about their results. And then, many programs will have EVS will do their own monitoring of cleaning. It is useful, however, to have external validation because that may improve the validity of monitoring. And so here's a study, was a sub-study from the BETTER study, where they compared marker removal as assessed by EVS supervisors versus study personnel. And this was 56 rooms in 2 study hospitals. And as you can see, EVS supervisors were giving rates of 80% reduction, whereas the study personnel found that it was only about 50% of surfaces were being cleaned based on marker removal. So really not that good for study personnel, and much different than from EVS supervisors. So the conclusion of this study was that this provides support for the recommendation that collaboration is essential. You need independent observers to conduct monitoring. And then I'll finish with some comments on 3 kind of challenges that we face in collaborating and working to improve environmental cleaning. So one is daily cleaning, as I mentioned, the trash and DAS approach. This image is just to point out that it's not necessarily easy to do daily cleaning. When the room is being terminally cleaned, all of the stuff that's in the room has been taken out, and so you are really able to clean well. So here's another room in our long-term care facility where their patients have a lot of their stuff in the room. So in long-term care in particular, but also in the hospital, you can imagine someone asking you to go in and do daily cleaning of this room. You're going to have to move a lot of things around in order to clean a lot of these surfaces. So doing good daily cleaning of surfaces is a challenge. However, at least for some patients, daily disinfection we think is quite important because it can reduce the risk for acquisition of pathogens from surfaces by staff or patients. It's really a source control. So here's an illustration of that with C. difficile. So these are a study we did where the black lines are, we're showing the percentage of hand cultures that are positive. So we went into C. diff rooms, put our hands down on the bed rail, bedside table, call button, some items in the room, and then we did a culture of our hands for C. diff. And you can see the black lines there show standard cleaning. So C. diff stays on surfaces, it doesn't die off over time. And so you can see that over the period of 5 days, about 80% of the time our hands acquired C. diff from touching surfaces in C. diff rooms. And in contrast, when we went in and did very good daily bleach cleaning of surfaces in the room, you can see that the open bars there, that the likelihood of acquiring our C. diff on our hands was much reduced. And that is because as the patients are being treated for C. diff, they were suppressing C. diff in their GI tract. Their diarrhea is getting better. So they're really shedding a lot less C. diff over time as they're being treated. And if you do go in and do good daily cleaning, you really can reduce the amount of C. diff that's on surfaces and that somebody else could pick up when they come into the room. And same thing is important for Candida auris, where the Candida auris contamination occurs very rapidly, often within 4 hours after completing cleaning. So it's recommended that you go in and clean at least on a daily basis. So we worked with our environmental services team to sort out an approach that would be most effective several years ago at a time when we were having a very high rate of C. diff and we wanted to implement an effective intervention. And so working with Robert Bankston, our chief of one of our EVS workers, we came up with an approach that was developing a daily disinfection team. The idea here is that we spend less time monitoring cleaning when we have a team that we know is trained and is going to do an excellent job. We don't have to spend as much time screening to make sure that they're doing a good job. So here's the team here. And when we did that, we were very effective at reducing environmental contamination. So optimal reduction in C. diff contamination occurred after we implemented a daily disinfection team. So the line there shows the percentage of surfaces, high-touch surfaces in rooms that were culture positive for C. diff in C. diff infection rooms. And so we would go in, and this was not after completion of terminal cleaning. This was while the patients were in their room. And you can see at baseline, we're getting lots of C. diff from the environment, 60 or 70% of the time. We did fluorescent markers alone, and that improved the thoroughness of cleaning and modestly reduced C. diff cultures, but not tremendously. We used a UV device, started using that. That reduced things more, but still not where we wanted it. And so you can see the final line there is our daily disinfection team. When they started going in and doing excellent removal of fluorescent markers, you can see a 90 to 100% removal of fluorescent markers. We then basically reduced C. diff contamination in the room on high-touch surfaces to zero. So this is one approach that can be very effective, having for certain areas such as decontamination of C. diff rooms, having a dedicated team that's doing that work. Here's another example of collaboration between EVS and clinical personnel to improve cleaning. So this shows reduced acquisition of VRE after implementing cleaning in an ICU by EVS and clinical personnel. So this is in Chicago. They had an educational intervention in an ICU. So this is one unit for EVS staff and clinical staff. They decreased environmental contamination. That decreased hand contamination of personnel, presumably because they're picking up less VRE from surfaces that were contaminated. And it decreased VRE acquisition dramatically. So the important point here is that, first of all, this is one ward, so it may be easier than an entire hospital to improve cleaning. But the clinical personnel were asked to assist, were told about the importance of cleaning. They were assisted by performing some cleaning of items that EVS were reluctant to touch, that were right next to the patients, and by removing obstacles that might interfere with EVS cleaning. So kind of facilitating excellent cleaning by EVS. So this kind of collaboration, I think, worked very well here. So that's the first challenge, is daily cleaning. Second challenge, portable equipment. So as we all know, often contaminated, rarely cleaned. Oftentimes we don't know who's supposed to clean it, and it's been linked to outbreaks. And then this is just an illustration of how often portable equipment can move from patient to patient. All of these lines show trips by transport chairs in our facility over a 4-day period. So there were hundreds of trips where our transport staff were picking up a patient, taking them in the transport chair to physical therapy, to the pharmacy, to radiology, and back, with lots of potential for interaction between patients from long-term care and acute care, all interacting in specialty care clinics, physical therapy, et cetera. And then the importance of portable equipment, I think, is the discussion about this has really been increased by this trial. So it's called the CLEAN randomized trial, a study that was done in Australia. They had 10 non-ICU hospital wards. They did 3 hours of additional cleaning of shared equipment every weekday. They improved cleaning, fluorescent marker removal increased. And then they noticed that they had a 5% absolute reduction of HAIs in this facility, a 35% relative reduction in this randomized trial. So a high quality study suggesting that if we do a better job with portable equipment, that we might actually impact HAIs. So this study, I think, has got a lot of people talking about what we can do to improve cleaning of portable equipment. And I would just mention there's very little literature on interventions to try to improve disinfection of equipment. Here was a systematic review from last year where they identified only 8 studies. They included stethoscopes interventions as part of their grouping of studies. Only 4 of 8 reported improvement. Even when they were trying to do interventions, they weren't effective sometimes. Here's one example, an intervention to improve ultrasound cleaning where they use fluorescent markers, education feedback, and this was actually effective in improving marker removal. And similar to what we do in our facility, they attached a canister of wipes to their portable ultrasound. So there's a lot of room for more work on interventions to improve cleaning of equipment. We're interested in far UV light or other technologies that might be effective. As I mentioned earlier, we received some funding after doing this study from the company that makes this, so just be aware of that. But we found that far UV light is very effective for decontamination of equipment, providing really a slower than regular UV because it's less intense. But over 45 minutes and 4 hours, we saw 4 log reductions on many sites in MRSA. And you can see how this would be set up in an equipment room. You put one light on each side of the room, and we're seeing pretty good results. So I'll finish with challenge number 3, which is new technologies. So start with this story. So many years ago, 2009, during the during one of the pandemics, we were approached by a company that had a new cleaning product for us to test. It was called the Fogmaster Junior. And this product is a handheld fogging device that delivers a mist of a quaternary ammonium compound. And that the technician for the company came in and demonstrated, and he would spray a small amount of this in the room, and he would say, that's effective, it's disinfectant. We would say, well, the surfaces aren't wet. He said, that doesn't matter, it doesn't have to be. So this is an EPA registered disinfectant. It shows, and he had data showing a 5 log reduction, and it had been purchased by some Cleveland area schools during the swine flu pandemic. And of course, it's dangerous spraying a quat around. And you can imagine that this actually doesn't work at all. If you're going to have a quat, you have to get the surface wet and it has to have contact time. If you're spraying a small amount of a mist in the room, it's dangerous and not effective. And so we have tested subsequently over the past 16 years many technologies, and I would just tell you that about 10% of them, I would say, are like the Fogmaster Junior. They really don't work at all. And then a lot of them have caveats that they work, but maybe not quite as well as they're being sold as. So environmental cleaning and disinfection is kind of has all of these issues that we're all often approached by people who are selling products. We're plagued by suboptimal evidence, opinionated experts, and money. People make a lot of money from these products, and so there's a lot of uncertainty and controversy. So it is essential, really, for environmental services personnel who are often approached by these types of companies to work with infection prevention to try to work together to sort out whether things are effective or not. So how should we evaluate new technologies? First of all, lab testing. The company should be able to demonstrate microbiologically that their product works. In a lab setting, EPA or FDA registration is helpful. Real-world testing is necessary. You would like to show that it actually works in a real-world setting. And so I would just mention that the Fogmaster Junior showed lab testing data and an FDA registration, but had no real-world testing it would have demonstrated that it did not work very effectively. And then if it's made it into guidelines, that's kind of the gold standard for a technology. So one example, additional example I'll give you is continuously active quaternary ammonium disinfectants. So these products had lab testing plausibility. They're effective. They persist despite what's termed with wear testing. They're effective in real-world settings. So they actually had a study published in Clinical Infectious Diseases where they decreased HAIs by 36%, even though they were applying the product only once every 4 months. They have the EPA registration for 2 products. They were not recommended in guidelines. And so the problem with these products is that on further investigation, there are really some issues. So the lab test methods that are used that show a 5 log reduction can exaggerate efficacy. It makes it look, you're putting a liquid suspension on the surface, which is not what happens in the real world where you're touching something with a dry inoculum. Heavy end application is required. So wiping with a wipe is not sufficient. You really have to spray a layer on that's basically sticky. And in clinical studies, you can imagine they found mixed results. These are no longer commercially available. One company stopped selling them, and the other was taken off the market by the EPA when they couldn't validate their claims. So just an illustration that even when products have a fair amount of this evidence, there is a potential for them to not work quite as well as expected. And then, final comment is that, cost, in addition to whether finding out whether devices work or not, you were often approached by companies that are comparing. They all have the same device. So here are four, I should say, uh, low pressure mercury UV room devices. And as you can see, the one on the right, device 4, is a little cheap, little $6,000 knockoff, which really didn't work very well unless you ran a really long cycle. But device 1 costs $125,000. Device 3 costs about $20,000. They're equally effective. And so if you are an EVS person or who is looking at purchasing one of these devices, you should be aware and collaborate with infection prevention, because you may find that you could save a significant amount of money because devices that claim to be superior to one another may not be. And then I'll just point out our collaborators. I have a lot of excellent environmental services collaborators here at the VA. So Robert Bankson is our chief of EMS at the Cleveland VA. He is an excellent proponent. He was really the person who helped set up our daily C. diff cleaning team. Ben Guerrero and Trina Zabarsky are with the National EVS program, are excellent collaborators as well. And so in summary, understanding the characteristics of disinfectants is essential to ensure correct use. A variety of factors may contribute to ineffective cleaning and disinfection, and this requires monitoring of processes and collaboration. There are a number of challenges that we still face that we need a lot of work to address: daily cleaning, portable equipment, and new technologies. And with that, I will stop and take questions.
All right, thank you so much, Dr. Donsky, for that great and very timely content. Before we go to questions, I just want to remind the audience, for CEUs, please click the link provided in the chat or scan the QR code to get to your post-test. You will also receive an email with a link to the post-test and a copy of the presentation. Okay, so let's move to questions from the audience. We have a lot coming in for you, Dr. Donsky. The first, I'm going to combine a couple on automatic dispensers. We had a lot of those coming in. So one question was about, are there directions for use that state how often they should be tested to check the amount they're dispensing? And if not, do you have a recommendation on how often these systems should be tested?
So no, there's really no recommendation for testing using the quad strips or pH strips. So we recommend, so the VA has set up a program where we recommend testing every time you place the bottle, because you have the potential to place it incorrectly. Every time you place the bottle of concentrate, and then intermittently between at least once a week, we recommend doing testing.
Great, thank you. Also talking about testing, for ATP testing, there's a question about how do you determine what level of organic material is acceptable when you're doing your post-clean measurements?
So that's one limitation of ATP, is that there really is not an absolute standard cutoff. So for one of the devices they use 200, so I think it's really just you ask the company that's providing the device that you're using if they have a specific cutoff. So the one that we've used most frequently gives you a 200 cutoff as acceptable.
Thank you, that's great. There are also a lot of questions around microfiber cloths. So a couple of questions came in about, do you have thoughts on using microfibers repeatedly compared to ready-to-use wipes, for example? And then related to that, there was a question about, there's microfiber cloths that claim to reduce organisms by 99.9% just by themselves. So thoughts on both of those things related to microfiber.
So I think wiping, there is, you get a pretty good reduction just with the mechanical wiping itself. You can get a 99% reduction. The problem with that, of course, is that if I reduce 99% of the contamination on my bedside table and then I go and wipe my bed rail, I can just transfer those organisms over to the next surface. So you really need a disinfectant to adequately reduce contamination, in my opinion. then what was the other question? Microfiber versus ready to use?
Yep, that's it.
Yeah, I don't have a strong, I think both can be effective. Um, I, I don't know. It is a question, when do you have to replace microfiber if you're reusing those cloths over and over again? Do they start to lose efficacy over time? Um, I don't really have a good answer to that question, to be honest with you. I've seen it both. I've seen people saying they last a very long time, and others saying that they start to lose some of their activity.
Fair enough. Okay, let's just take one or two more because I see you have another meeting. So there's a couple questions about figuring out who cleans and disinfects what in your facility. It sounds like that's always a challenge for folks. How do you address that at your facility?
So not as well as I would like. The EVS really focuses on the patient rooms. Clinical personnel are supposed to be um, doing working with portable equipment. As you saw from our data, though, we're not doing very well. So this is actually something we want to work on now, is trying to find a strategy to improve cleaning and disinfection of portable equipment. Everybody has the same challenge, I think. Again, we do simple things like put a canister of wipes on the portable ultrasound device, et cetera, to try to make it as easy as possible to clean.
Great, thank you. Okay, I think we will stop there. Thank you again, Dr. Donsky, for a great presentation. This does conclude today's webinar. Thank you all for joining us and have a great day.